Jonathan Waxman joins us now, Professor of Oncology at Imperial College in London. He joins us from central London, and also Seth Gilman here with me in the studio, bereavement counsellor with me now. Thank you both, gentlemen, for joining us. First look at these comments. You feel he's almost being flippant, but I think that's probably not true. Jonathan Waxman, he's actually trying to make a point. Do you take that point?
No, I'm an ambitious oncologist, and I'm really pleased with the outcome of cancer research over the last 30 years. Death rates from breast cancer have fallen by about 30%. 98% of people with testicular cancer are cured. This is the result of cancer research. I think his comments may have been influenced by a little bit of Christmas tipple, because Richard Smith is a respected doctor and a great former editor of the BMJ.
Is there not, Professor Waxman, is there not a feeling, a flavour in his comments, perhaps, that oncologists might pursue the cancer they're trying to cure a little bit too much at the expense of the comfort or indeed the ultimate satisfaction of the patient?
Not at all. I think that's completely untrue. Our ambition, our drive is to look after the whole person.
Seth Gilman, what do you make of the comments?
I think what he's trying to say is that if people are given control over their own treatment, then that's the best way to go, and that what we shouldn't do is over-medicalise, and that there needs to be a point where treatment should be thought of, or it should be considered to be withdrawn, so that the person's last few months or weeks, they can enjoy those months or weeks with their family and not have treatment after treatment after treatment, which may make them feel worse and, in fact, that may not improve or extend their lives any further.
How do you decide when that moment comes, when you start to pull away from the medical approach and start thinking about the human being's approach?
Well, that's very difficult, and I think the patient themselves need to be included in those decisions. And I think we've seen from the Linda Bellingham case recently, where she had made the decision to stop treatment in order for her to be able to make the most out of those, the time that she had left. And I think that patients really need to be included in those kind of decisions, and their families.
Professor Waxman, patients included in those decisions?
Of course they are, and it's extremely arrogant of anybody to think that we would not include a person in decisions about their life and death. And having been involved, actually, in the care of Linda Bellingham at one point, I would say that the doctors that were involved in that case did their best to involve her in the decisions about her future treatment. Life is sweet, life is precious, and I think it's a great arrogance to think that the doctors would be so oblivious to the cares and concerns of a patient that they wouldn't regard their well-being at the time of death. So we don't pursue treatments indefinitely. We don't try to treat and treat and treat without a consideration of how the person is. So I think that we are most concerned with the care of our patients. We're most concerned about the quality of their life. We're most concerned about making sure that the treatment suits the person.
Seth Gilman, is that your experience, that cancer patients particularly are involved right up to the last moments?
I think that's quite variable. I think that it depends on where you are and which doctors you're working with. But yes, I completely agree that I think that people should be included, and if Professor Waxman says that's the case, then absolutely I think that's the way it should be. I think the quality of our death is just as important as the quality of our life, and that in our culture we don't always talk about these things, that death is actually done somewhere else, and that we really need to maybe expand the conversation so that we can have a choice and some kind of decisions over the way that we all go, because it's going to happen to all of us.
Well, here they're talking to expanding the conversation. Professor Waxman, do you at least think that a sidebar of Dr. Smith's comments could be that we do have a revisit at least this issue of patients approaching terminal illness and palliative care, and have a little look again at our attitude towards that?
Listen, every one of us has to go. Every one of us has to leave the planet at some time. And our intention, of course, is to leave at the age of about 107 in the arms of our beloved. But unfortunately, that silent death is not the fate of all of us. But regardless of all of the sort of trivia around this conversation, we should know as a population that there are drugs that are available to mitigate the problems that are around death, to deal with pain, to deal with anxiety, so that death should be good and death should be without suffering.
What about patients who go on their own, perhaps, to get a diagnosis for the first time from an oncologist? They barely hear what's being told to them because what they're being told is so shocking. They end up having little or no discussion, and that sets a trend which may continue for many months of treatment, where they become entirely passive and dependent on every decision by their attending physician without really being involved in making any decisions themselves.
I think your initial point was a very good one, and our concern in medicine, of course, is that patients should be dealt with properly. Mostly diagnoses of cancer come from surgical colleagues, and the surgical colleagues, I have to say, aren't the most skilled at conveying news. However the news is given, however the information about diagnosis of cancer is conveyed, of course it's dealt with by shock and by disbelief. It's very hard for people to confront this news. There's no great way of saying things.
Can I interrupt you there? Sorry, Professor Waxman, running short of time. Seth Gilman, do you find that there are different arenas in the medical world, the counselling, the hospices, the surgeon, as Professor Waxman pointed out there, the consultant, where patients have a different feeling of what they're surrounded with, what sort of attendance in terms of their own emotional needs are being looked after?
Well, of course, and doctors are there to look after us physically and maybe aren't always as specialised in the emotional side of things, and that's where other kinds of specialists come in, like counsellors and other kinds of psychological treatment or psychological support can be really helpful. And those things really need to go together. We can't have a one-size-fits-all where everybody gets the same kind of treatment. We need a kind of a more personal approach where people get the support that they need, both emotionally and physically. It's really important.